Hello, good afternoon, everybody.
Hi, everyone. Welcome to our talk today. Today, we're joined by Dr. Sharif Boutros, Medical Director of the Lefcourt Family Cancer Treatment and Wellness Center at Englewood Hospital. Dr. Boutros will lead a candid discussion on cancer prevention, the importance of early detection and screening, and innovative treatment options. If you have any questions during this presentation, please feel free to comment them below in the Q&A box. To access it, you will see Q&A on the bottom of your screen. Just click it and fuel in your questions. We will answer everything at the end of the talk. You'll also have the ability to turn on captions for this presentation in any language of your choosing. The instructions to do so are in the chat box below. As you may all know, the LiveWell Center hosts these monthly health talks to share important information from leading experts. So to learn more about upcoming talks, please visit our website, which I've also commented in the chat box. And at the end, we would greatly appreciate your feedback through a short survey. It really helps the center improve our future sessions. So please join me in welcoming today Dr. Sharif Boutros.
Thank you very much, Angela, for this nice introduction, and thank you all for joining us today. It is really a privilege to talk to you today and talk about a topic that's very close to my heart about cancer prevention and screening. So without any further ado, I will start by sharing my first slide. Can you see it? Angela, can you see that?
Yes, perfect.
Absolutely. So let's start with first fundamental question. What is cancer? Well, our body is made, as you may know, about trillions of cells. And on a daily basis, maybe around 1% of the cells get a turnover, died, and new cells arise and new cells get generated. And these new cells that are generated embedded in their genome, in their genetic material, a programmed cell death mechanism that they cannot live forever, they cannot grow forever. At some point, they get eliminated by our body. And during this replication process and turnover process, for multiple reasons that we will discuss, there is some kind of abnormality that happen to this genomic material, to these genes. And the cells, instead of having this programmed cell death and stop of growing, they grow indefinitely. And they give rise to new cells that have the same abnormalities and accumulate mutation and abnormalities in their genes to grow and escape the control and the checkup of our immune system in a way that they start growing, forming their new blood vessels, invading blood vessels, invading lymphatics to go and spread to other distant organ when it's called metastatic disease. So is cancer common? Well, unfortunately, yes. As you can see, 1 every 2 men or every 3 women will have cancer at some point of their life. New Jersey, as New Jersey citizen, we need to know that we are ranked 4th among all of the 50 states for 5 years in a row. So we have some definitely a problem to fix. We need to be cautious about our risk factors. We need to do a little bit better for prevention and screening for cancer. Some, in fact, of this cancer, as you can see, are really high in incidence in our county, in Bergen County, as you can see, for example, here on this example, the thyroid cancer at the late stage, much more in our Bergen County than what we can see in the United States or even among the highest counties in New Jersey. So why we have cancer? Why cancer occur and why these abnormal cells lost their control and get really uncontrolled growth? What I want you to remember from this presentation, which is I think one of the most important take-home message, is that 50% of these risk factors to develop cancer is in your hand to control. There are some risk factors that you cannot control. Aging, we cannot control so far. We are all getting older with time. Your family history, basically your genes that you are born with, you cannot control it. The environment that you are around and surrounding you cannot, to some degree, control it. But 50% of the cancer risk factors is in your hand to control. Most importantly, smoking, unhealthy diet, excessive alcohol consumption, excessive sun exposure, and infection like human papilloma virus and correlation with the uterine cervix cancer, and hepatitis B and C with correlation with hepatocellular cancer, the cancer of the liver. So that's, I think, a very important message, that 50% of the risk factors are modifiable. We can fix it. So, okay, how to do it? Well, part of it is you, part of it is the health system where you are. You alone can do a lot of stuff. Eat healthy diet, Mediterranean diets, a lot of fruits, vegetables, whole grains, exercise regularly. And the secret word is regularly. It is not like once a month excessive exercise. It is very important to do it on a weekly basis, on a regular basis, about the recommendation about 150 minutes per week. I mean, don't go very strict with the number, around this number, about 2 to 3 hours per week of exercise. Maintaining a healthy weight is very important. Completely avoid tobacco. That's the first thing that you can do to improve your health, and limit, if you can, to completely no, but at least limit alcohol, and use sunscreen to protect your skin from sun exposure. Another part of this prevention program need to be, in fact, in correlation and in collaboration with the health system where we are offering it. Vaccination against this infection, human papilloma virus, hepatitis, as we discussed. Screening for the common cancer, mammogram for breast cancer, colonoscopy for colon cancer, low-dose CT scan for smokers who are at a higher risk for lung cancer, and screening for prostate cancer with methods including PSA test that need to be discussed on case by case with your doctor. Most important information, these screening modalities are not secret, are not hidden, are not unknown. It is very clear, and it is, in fact, kind of now being part of any primary care physician routine health care visits. So regular checkup is the key. Regular checkup with your primary care doctor to get you, in fact, covered with all of the screening tests that's needed to be done for you at specific age need to be performed. So how the screening is important, how this prevent death or prevent new cases. You can see 1 every 5 deaths can be prevented by tobacco use. I mean, tobacco cessation. So that's basically 1/5 of the cancer deaths is related to tobacco, 4% about excessive body weight. For new cases, about 12% are related to infection, 4% about alcohol consumption. So these are a real number, and these are true large important portion of cancer occurrence and cancer deaths that, again, as we said, can be to a large degree prevented. How we do the screening for the common cancer, I mean, I again, as I say, it is not a secret, and the primary care physician know very well about it. And there is even some, as we will see, a campaign of reminder, either as in your EPIC chart on the electronic chart to remind your caring team that you are at the age that will require some screening, or as well for you as part of a healthcare system. For example, here at Englewood, we send a electronic messages campaign that, hey, I mean, you are maybe eligible for breast cancer screening if you are at this age group of 50 to 54. You get that on annual basis. For the ages of 25 to 65, women get human papilloma virus DNA test, colorectal cancer, if you are there are many options, and it's kind of a boutique, and we'll spend a little bit of time to talk about colon cancer today because there's different ways of screening for it, but the gold standard is colonoscopy, and it can be done every 10 years, so it is not really excessive screening. Once every 10 years, if they find nothing as alarming features on the last colonoscopy, no polyps, no high-risk features, they can make it every 10 years. Endometrial cancer for women after menopause, we need to alert them. Any abnormal bleeding, any menstruation after menopause is definitely a red flag. Is not a normal menstruation, it's bleeding, and that should attire our attention for a high possibility of having endometrial cancer. The lung screening, low-dose CT scan that we do it for smokers who smoked more than 20 pack years. 20 pack years meaning that they smoke a pack for 20 years or half a pack for 40 years or 2 packs for 10 years. Basically, if you do the math, the multiplication of these two factors between the number of packs and the years, if it is 20 or above, they are eligible for a lung screening, the low-dose CT scan. And men over 50, we highly recommend to have a discussion with their primary care or urologist to discuss the role of PSA and detecting prostate cancer. So what about this colorectal polyp? I know that we have previous discussion with the cancer team about breast and prostate cancer, which are very important and common cancer. So I want to talk a little bit more in the next couple of slides about colon cancer, which is the most common, unfortunately, most common GI cancer. What's about it? Not that much of different of our presentation. Abnormal cells that accumulate mutation in their genome, and with this mutation start to grow. The good thing about this grow, it doesn't start to be very aggressive. It starts with an abnormal growth, uncontrolled growth of cells that instead of dying, they continue to grow. And these cells that continue to grow in a limited place, you can imagine in a limited space, and they continue to grow, they make a bulge. They make a mass effect, and that's called the adenoma. So it is abnormal cells that accumulate. They are not yet aggressive enough to invade the surrounding structure, the wall of the colon, to go to the lymphatic or to the blood vessels and spread anywhere. They are just local, but they continue to grow. And then with accumulation of mutation and time, these cells become more and more abnormal. And then they start, in fact, to form an invasive cancer. And this invasive cancer go and invade the wall of the colon. And it started from the inner layer of the colon, but after this inner layer, there are basically the layers that have the lymphatic and the blood vessels. When it achieves that, it has a tendency, or at least a chance, to spread to the lymph nodes and to distant organ, including the liver, when they spread through the blood. What's very important to understand, and that's why the colonoscopy is the gold standard for screening, is that about maybe 80% of this colorectal cancer arise from this phenomena that we talked about, that start with an adenoma and then an invasive cancer and then start to spread. And during that period of 10 years, from a small adenoma to be an aggressive cancer, 10-year period, if you had a colonoscopy and the GI doctor is able to identify this polyp and remove it, not only it treat cancer, it prevent the cancer. The colorectal cancer is preventable because you catch up early on this abnormal cell before it gets transformed into a real invasive cancer. And so that's basically the value of the colonoscopy on these cases. I want to share with you some great news that despite that it is a very common cancer, as you can see now, the incidence of colon and rectal cancer are getting less because of the increased awareness that we are doing for patients about this GI cancer, and because of also the aggressive treatment that we are offering. Nowadays, even the metastatic colon cancer that did spread, unfortunately, to the liver, we have a curative intent approach by I resected the colon and the part of the liver as well that has a metastatic disease, and we have a long-term survival and curative patient cured by this approach. And even if the cancer did spread to the lining of the abdomen, to the peritoneal membrane, which is not, unfortunately, not an uncommon site of spread of this cancer, we can still do a surgery that take care of the primary cancer and the lining of the abdomen, the peritoneal membrane. It's called the cytoreductive surgery, and HIPEC, basically giving the patient heated intraperitoneal chemotherapy inside the abdominal cavity to kill any floating cancer cells. So with that being said, the mortality from colon and rectal cancer are getting low. So that's good. So you can see here the mortality and the incidence of colorectal cancer getting low to all stage group except the younger group. The younger group, 0 to 49, is getting higher. Why it is getting higher? Well, there are some theories about it. I will tell you my, in fact, feeling and my theory about that are, one thing is that we have a little bit, the bar is pretty high to screen this group of patients because they are young. We think that they have less chance of having colorectal cancer. And the second thing is what we discussed, remember what we discussed earlier about the risk factors of colon cancer or of any cancer. Age is one of them, but tobacco, excessive alcohol use, sedentary lifestyle. So all of these risk factors put this patient at a higher risk. And unfortunately, our youth is more and more, in fact, going into this direction of sedentary lifestyle, of excessive tobacco smoking, of excessive alcohol smoking that put them at a higher risk. When we talk about the genes and genetic abnormality that's corresponding to colon cancer, we need to remember that we know about some part of it. We call some part of it as disease, like you may heard about Lynch syndrome, about familial adenomatous polyposis, about hamartomatous polyposis syndrome. But there are a lot of sporadic cases that are family-oriented, but not really having this genetic background. So that's why it is very important for young population when they get diagnosed with cancer to have a genetic testing to see like what's wrong with their genes, because that's maybe highlighting their tendency to have other type of cancer or to inherit a mutation that they can pass it to the next generation. Risk factors for colon cancer, not that much different than what we discussed before. We can summarize it in one or two words: sedentary lifestyle. So this is what we try to avoid for colon cancer and for most of the cancers that we will be discussing, trying to reverse the sedentary lifestyle, this all of these risk factors, all of this disease process that happen all together, what we call it a metabolic syndrome with excessive body fat, especially on the abdominal part, with the diabetes, the alcohol consumption, the cigarette smoking, and the lack of physical activity. What you can do against that to prevent it, as we said, diet is a key, regular physical exercise, high calcium intake. Aspirin has been proven to be a non-steroidal. Some studies suggested that it is definitely decreasing the rate of formation of adenomas, and hormonal replacement therapy for women after menopause, but that's need to be discussed with the physician because it may increase the risk of breast cancer, but it definitely decrease the risk of colon cancer for some patients. And the key take-home message, the key word is screening, because as you now understand, for example, colonoscopy is not only screening for cancer, but can prevent cancer because you diagnose it and you treat it at precancerous stage. So how New Jersey is doing with cancer care? Well, we are different. For example, here when we talk about cervical cancer, you see that we are screening not that bad. We are among the highest states that we screen for cervical cancer, uterine cervix. We are doing okay regarding the breast cancer mammogram screening. And we are doing a little bit poorer than the average other states regarding our rate of being adherent to colon and rectal cancer screening with any modality. I mean, we discussed colonoscopy, but there are other modalities that you may be hearing about, including a testing of cancer cell in your stool or blood in your stool. What you need to remember about this test is that they detect cancer. Maybe they detect it at the early stage, but you need to have cancer to be detected. However, the colonoscopy is not only to detect cancer, but to prevent cancer, because you can, in fact, interact with the process at earlier stage before the cancer being invasive and before the cancer start to appear as a precancerous condition on the adenoma. So this is our cancer center, your cancer center. It is an academic comprehensive cancer program. What that mean, academic comprehensive? That mean basically that we have the expertise in treating and taking care and honor to serve a large number of population with different type of cancer on a regular basis, that we are offering this patient multidisciplinary experience and expertise that reach a specific standard that get us to achieve this level of recognition, that we are trusted because of this level of expertise to train not only to offer our treatment, but to train the next generation of future cancer providers in our program, and also offering the patient clinical research that can give them a chance to have access to treatment that's not yet a standard of care, but in the research arena. So that our cancer center here, that as you know it very well, is have a multidisciplinary care, which is a program that's accredited by the American College of Surgeons, and for also the breast program, accreditation for the breast imaging center, and strong community outreach, education, and programs that we are participating in one of these activities today, and clinical trials, and what's very important, in my opinion, survivorship care. This is basically how we see the cancer care in our program. First part of it is prevention, that's what we are talking about it today. But the big vision, the big goal is to have what we can call it a cancer-free approach. We want to defeat cancer as much as we can, and make sure that our citizens and our patients that we are honored to serve are basically at a lower risk and free of cancer, or get treated as much as we can, get back to the community as a happy member in the community. So cancer prevention is very important, that education is, as we are doing today on the Live Well Center. Primary care is very important, and really stressing the thing that we can modify, including nutrition. Having strong screening programs with tax campaign, as we said, about lung cancer screening, breast cancer screening, and other type of screening, and that can be clearly managed between the patient, the primary care physician, and Englewood Health multidisciplinary care. The multidisciplinary care for patients who have cancer, that's not only the medical oncology, radiation oncology, and surgery, but integrative medicine, including really yoga classes, acupuncture, helping the patient to get over the stress. Sometimes not only the patient and their family, in fact, and their beloved, to get over this stressful time that with the cancer diagnosis. Cancer most of the time is not, as we say, an acute emergency, and we can operate on this cancer and start medication in relatively short time, but not as an emergency on the day of the diagnosis. But it is for sure a mental emergency. And for sure, it is a stressful event. And for sure, it is a life-changing event for the patient and their families, including their quality of life, including their communication with others, including their ability to interact and to work with their normal physical activity, including financial obligation for them and their families. So there is a lot of the multidisciplinary care that's definitely beyond the care that I provide as a surgeon or my colleagues in medical oncology or radiation can provide. Very important that when we cure the patient for cancer, we want the quality of life, not only the quantity. We want this patient to go back to the community as an active, happy member in the community. So we want to make sure that it goes back with, yes, no residual cancer, but also a serenity that he or she will be followed up by the team at a regular interval, that the patient know, in fact, what he had or she had as type of cancer, and summary of the treatment that he had and she has, and what other risk factors he can modify, what other cancer he is at risk for, and how we can screen for this cancer. One of the very deadly cancers that we have, unfortunately, is a pancreatic cancer. That's a cancer that I basically am specialized on. And as you may know, 80% of patients that come to any surgical clinic for pancreatic surgery, when they get diagnosed with pancreatic cancer, 80% of them are beyond the ability to be resected. Either they're locally advanced and the tumor did grow to involve local noble blood vessels or structure that will not allow a complete resection of the cancer, or it did already spread as a silent cancer and diagnosed only when it did beyond the location, beyond being located at the pancreas. And one of the things that's very important to do is to know if there are some risk factor for this pancreatic cancer. Can we screen for it to diagnose it early, even on a precancerous condition as we do it for the colon, or no? And that's one of the things that just happened at our cancer center, that we started the program for basically personalized pancreatic cancer prevention program. And every word here means something. It is personalized. That means it is tailored and adjusted to the patient, to each patient, about his or her risk factors, the genetics, history, and the family history. It's a prevention program. It's not to treat pancreatic cancer. I mean, we treat pancreatic cancer in our cancer center regularly, but here we are aiming to prevent it by early diagnosis and interfere early, sometimes before having the cancer to occur. So another thing is the young onset colorectal cancer. You may remember that we discussed it on previous slides, that unfortunately the incidence of colon and rectal cancer in young population is rising for multiple factors that we discussed. So here we are making a program that's basically focusing on this age group, because this age group has different requirements and different interests compared to the elderly group. They have a little bit more concerned about ostomy and physical appearance. They have more concerned about fertility and growing and having family for the future. They have more genetic abnormality that predispose them to get the cancer to start with at earlier stage. Their survivorship and getting them back to the community as active member require much more effort because the cancer occurred at early age. The financial burden and financial toxicity of the cancer at young age is much more pronounced. So what we are doing here, from screening to survivorship, we are doing reformatting our cancer programs into a comprehensive and integrated program from prevention. For example, here we talk about the lung cancer. It's clear about prevention. Okay, we need campaign about smoke cessation, that's for sure. And then screening, we talk about the lung cancer screening the campaign that we are doing with a low-dose CT scan to identify the abnormal nodules that arise on the lung as a first sign of lung cancer. When this happened, we started a program now of a lung nodule clinic, because the worst thing that we do as well is with this technology, we screen everybody who meet the criteria, and then we find large number of lung nodules. Every one of them need to be resected and go for surgery and really attire the attention of the physician and increase the anxiety of the patient. Not necessary. So each of these nodules need to be viewed separately by experts to really identify the high-risk nodule that will require a little bit more investigation with interventional pulmonary doctors, the IP, that will who will be able to go and chase one or two of this nodule and get a biopsy of them to see if they're really cancer or they are stable enough and they are really a benign nodule that has been there forever, or benign nodule that we just discovered, but we can safely monitor them. If lung cancer got developed, we have the thoracic surgery and the multidisciplinary care with chemotherapy and go to survivorship. So that's a modality of just giving you an example what that means of a comprehensive or integrated cancer program. Here we are talking about the lung. So another slide that is again close to my heart, because I did the study for 4 years as well, about the Mediterranean diet, about the omega-3 fatty acid. And to a cancer that's very interesting for me, the pancreatic cancer. Does it make sense that the Mediterranean diet scientifically can be correlating with a prognosis, with basically having a better survival or even preventive to some degree to pancreatic cancer? Absolutely yes. So the omega-3 fatty acid is an anti-inflammatory effect, and inflammation is a very important component of or a precursor of cancer, not only as a hepatitis B and C, and we talked about the liver or human papilloma virus and cervical cancer, but in any form of cancer, inflammation play an important role. And omega-3 fatty acid is an anti-inflammatory, in fact, play a major role in controlling pancreatic cancer and having this pancreatic cancer a better survival. Here's the very last slide, so we can have enough time to discuss any question. The survivorship program. The idea of treating cancer and preventing cancer is one thing, but once we treat the cancer, we want this patient to go back to the community as an active, happy member that can contribute and have quality of life, him and his family to be happy. So how we do that? Well, things like treatment summaries. I mean, basically increasing the knowledge of the patient and the family. We behave much better if we have really clear understanding that I had this type of tumor, that's what stage, what treatment I got, what's my expectation, what I should do, what's the screening program for making sure the cancer will not recur, helping this patient to go back to a rehab, to get a little bit establish their strengths and nutritional service to establish their good nutritional status, psychosocial support to make sure that they go back as a happy member of the community, and financial support. We are very careful about the financial toxicity of cancer, and we are very careful to make sure to have in our cancer program providing financial navigator who take care of the financial situation for all cancer patients as they need it, to make sure that we have the best result. So I made it short because I'm sure that, okay, I can talk for cancer for hours and hours, but more importantly is that I answer some of your question and your concern is realistically, I will not be able to cover the topic in 20 minutes, or 30 minutes, but I'm very happy to take some question and answer. So I will stop sharing at this level, but happy to go back if there is any slide of interest.
Thank you so much. So we're going to enter the question and answer period now. For those of you who joined late, you can ask a question by clicking the Q&A box on the bottom of your screen and typing in your question, and I'll read it out loud. We do already have one question, Dr. Boutros, so I'll read that out to you.
Yes, please.
For higher calcium intake, how much is recommended? Also, I've heard taking too much calcium may be detrimental to the heart. Not sure if that's true.
It can be detrimental for the heart. It can be detrimental for the kidney. I mean, too much calcium can precipitate kidney stones as well. Well, I mean, it is all of this recommendation need to be done in conjunction with consultation with your primary care doctor. It is completely understandable that before giving you any calcium supplement is to measure your calcium intake and your calcium level in your blood to see how much calcium is in your blood. At least is in fact do not allow calcium to be low. That's on the low normal. That's not good because higher calcium is kind of preventive and have a role in cancer control. But how much, there's not a secret number, but I think this need to be conjunction in case by case with your primary care physician.
Okay. We also have another question. Someone has commented on there being a lot of discussion around microplastics and their influence on cancer. On the same note, we received another question asking if microwaves, air fryers, etc., can cause cancer as well. Can you provide any comments on these?
Well, excellent questions. I want to reassure you about a couple of things that this the equipment that you have on the market, it's been definitely checked for that. And a well-functional microwave should not have any effect on increasing the risk of cancer. The radiation that are produced by the microwave are not ionizing radiation. In another term, they will not strong enough to alter the DNA and have a mutation for the user. And even the food that is heated by the microwave will definitely not be radiated. It will not be radiated food. So to answer the microwave, a well proper functioning microwave machine should not be having a higher risk. Regarding the air fryer, I think that your question is related probably to the acrylamide, which is a product that is produced with excessive heat of basically fats and starch. And in animal models, we know that the acrylamide at a large dose, continuous exposure, predispose animals to cancer. Is that the case for the air fryers? Again, not really, because they are in fact checked for that and to make sure that they are not producing this acrylamide to a significant portion that could affect the human health. So the short answer question for your beautifully drafted question is that well, it is unlikely that this will correlate. It's more to be a myth than a reality in functional functional equipments of a microwave or air fryer.
Okay. They also asked about microplastics and some of the discourse around that and its influence on cancer.
Well, to be honest with you, it is on the research. I do not have a conclusive answer that I am ready to share. I think that it is kind of research. There is a lot of things that is on top of our interest of researching of factors that contribute to cancer. And maybe that's related, or we group that in all factors, including environmental exposure, that include all of these questions that we do not know. But till we have a formal answer, I hate to just share premature information in audio.
That makes sense. Okay, someone else has also asked, why is obesity a factor in getting cancer?
Well, this is a beautiful question, because people feel like obesity is just fat. So why fat in the belly or somewhere else will increase my risk of cancer? Well, obesity, we have to understand it and to accept this concept that obesity is inflammation. So obesity is an inflammatory process. And per example, I'm giving you an example. A lot of the hepatocellular cancer, the cancer that arise on the liver, started, yes, with hepatitis B and C, but we eliminated that. We can prevent hepatitis B and C with the vaccines and minimizing the risk of hepatitis C and even treating hepatitis C. But why the risk, why the numbers, and why the incidence of hepatocellular cancer is going up is because of the fatty liver, because abnormal fat accumulation on the liver, because again of the obesity and because of sedentary lifestyle and the metabolic syndrome. Fat inside the liver, as well as fat in any other organ, create an inflammatory milieu that encourage basically the cancer to occur. In another form as well, you need to remember that fatty tissue have also a hormonal tendency to make estrogen. Like we know that the estrogen level in obese patients is much higher than thin patient, and so it also contribute an hormonal imbalance. So why obesity is forming or a high risk for cancer? Because obesity is inflammation.
Okay. Another question we have is, how do you explain that when people have a certain healthy diet, they're eating very healthy, they possess healthy behaviors like not drinking, not smoking, no alcohol, but in the end can end up with lung cancer? How do we explain?
And I never smoked. And I never smoked. And
Yes.
we all see this patient that never smoked and have lung cancer, and other examples of heavy smoking smokers like Winston Churchill with his cigar all the time.
Yeah.
Never had. We had this example. You just don't go with the exception and make it the rule. We definitely know that it has a high chances of getting cancer. That means that every single smoker will have cancer? No. Or every single non-smoker will be basically prevented or completely immune from cancer? Absolutely no. There are other risk factors that we discussed, including the genetic, the part that you cannot control, something that you are born with, something related to your gene that make the cells abnormal growth happen, as we discussed early on our discussion, despite of other risk factors. I want also to highlight the environmental factors here when we say that they never smoked. And do not underestimate the secondhand smoking, being on an area that's having a high smoking incidence, and you smoke cigarettes without smoking cigarettes. In fact, that's one thing. And the exposure of chemicals or radiation at work, if you are an exposed area. So that also can increase your risk without having any other smoking habits.
Okay. We have a couple more questions. I'll try and combine some. Someone has asked, are there any modifications in your own home and your own choices that you can make regarding these daily objects, which I think they were referring to the microwave use, the air fryers. And someone also has asked if hair dyes, so other modifications that you can make, can they be a cause of cancer as well?
Well, again, for the microwave and the air fryer, make sure that your equipments are new and are properly function. And if you see any dysfunction on them, do not allow this to stay at your home. Just to make sure that there is no leak, there is no abnormal indentation, the door is properly closed, stuff like that that are very important. I think I will, because this question is more or less covered with previous discussion, I want to highlight one thing that you can do and modify at home. Open your fridge, take out all of this unhealthy diet, fill it up for me with healthy, good food. Make sure to spice your food well and to like it, because one of the most important thing why people are not really getting the healthy food is that there is again, it's a myth that the healthy food doesn't taste as good as the fried one and the fatty one. So make sure to cook it well. And there is a lot of I think we have at the Live Well Center some cooking classes to make
We
sure that
do.
how we can make the nice food and the healthy food really taste nice. And one thing that I want as well to highlight to you, our taste buds are very modifiable. Like we like what we used to like. For example, people cannot take coffee without like 2 or 3 teaspoons of sugar because they get used to that. However, if they start taking their coffee with no sugar for 2 or 3 weeks, now it tastes very well for them and they can avoid the excessive sugar. So after we do surgery sometimes and the patient is not, we call it MPO, without eating or drinking for some time, we start feeding them and they say, you know, doc, I mean, I'm able to eat, I'm not vomiting, I'm not nauseous, but nothing tastes well at all. I'm forcing myself to eat. That's very classic. And we always tell them, okay, your buds, your taste buds are not functioning for some time. They need some time to recover. But once they recover, they start, you have to force yourself at the beginning and then they start. Same thing apply here as well. If you get used to the healthy diet, you will be amazed that it tastes really good, and especially if it is nicely spiced and nicely cooked in a way that the Live Well Center can teach you. I'm the last one to teach you that. I'm a very bad cook, but I'm sure that the Live Well Center will give me cooking class. But when you cook it well, there's a good chance that you will love it and you will taste it much better than the other non-healthy diets. So the take-home message, if you want to modify something at home, is not the microwave, is not the air fryer, it's in fact your fridge, and control it a little bit more.
That's a good tip. Okay. Perhaps I'll ask you one last question that we have, and then we can wrap up. Someone has asked, why does chemo produce such horrible side effects?
Well,
it's a big
it's a
question.
good question. I don't know. How long do we have? Because I
Your
can't.
shortened response.
Sure. So let me tell you something. What the chemotherapy is doing. The chemotherapy is basically trying to kill the cell that are multiplying and growing. But Dr. Boutros, you told us that we have trillions of cells in our body and the turnover is about 1% per day, that all of our normal cells grow, die, and grow. Is the systemic therapy, the chemotherapy, is really targeting this only cancer cell to some degree, but not all of that. So some of the rapid turnover cells, the hair follicles, the GI tract, epithelium lining of the GI tract, get affected by the chemotherapy. It is not really selective for the cancer cells. So it is basically a systemic therapy that go all over the body. It's important for the patient that have a disease spread or have a chance to disease spread all over their body, because it's a modality that goes all over and can control the disease all over our body, but it comes with a side effect. Nowadays, we have more and more ability to select chemotherapy specific for some type of cancer, to select systemic therapy that's not chemotherapy. It's called the targeted therapy, much less side effects and targeting this cancer in a specific area of its metabolism, of its cell growth, to kill specifically these cancer cells in one place or all over the body. We have the immunotherapy, which is a systemic therapy as well, but basically enhancing our own natural immune system to go and attack cancer cell instead of giving chemotherapy. So chemotherapy, yes, it has its role. It is toxic by definition to the body, but much, much more toxic to the cancer cell. But nowadays, this toxicity is minimized by reducing the dose when it is appropriate, when it is needed, selecting the appropriate dose for each patient according to his or her cardiac condition, kidney condition, liver condition, not to injury other organs, and being closely monitored by experts in medical oncology. And when it is needed, giving a targeted therapy or immunotherapy rather than chemotherapy. All of these options what make a cancer program a little bit higher or at academic level as we are compared to any other programs.
Okay. Thank you very much, Dr. Boutros, for a very insightful discussion. I think that's all
Thank
we
you.
have for today.
Thank you for having us.
Oh, of course. And like I said earlier on this presentation, we do have a survey that we like to give out to our attendees. This just helps shape our future sessions to really hear what you all want to learn more about. So please click on the survey links in the comment box. I will stay on this webinar for a little longer so you can all access them. Thank you again, Dr. Boutros. We hope to have you
Angela,
again
thank you
soon.
very much.
Thank you
you
so
very much for
much.
hosting me, and it was a really wonderful opportunity to interact virtually with the audience. And
Yes.
hopefully next time we'll be in person.
I hope so too. Thank you so much.
Thank you. Bye.
Bye.